First of all, hello, everyone. I'm Catherine Bonniot, and I am the Deputy Director, as you heard, of the Smoking Cessation Leadership Center. And I am also privileged to be the Director of the National Center of Excellence in Tobacco-Free Recovery. And I just wanted to say, amazing story, Norma. I had no idea. I just am so in awe of how you're continuing to champion the cause. And then with Dr. Friedman, the work in LA, just to think that you all have done so much to bring sort of that equal access, right, to cessation resources for everybody in the community and just sort of saturating. If we can get that done in the nation, in the state, I'm sure we're going to be saving lives, continuing to save those lives. And apologies for the sun, but if my glasses go a little dark, you'll know why. It's a sunny day here in San Francisco. All right, so I've been tasked with talking to you all about tobacco use and behavioral health, and specifically getting into an initiative that we had here in California and how it can relate to you and your work, and then highlighting a new bill that is across the state, and then ending with a great set of resources so that you can go out there and do good work. So get going here. To give you a quick idea of our center, we've been around for quite some time. As you can see, since 2003, we're a program office of the Robert Wood Johnson Foundation, but we are housed at the Department of Medicine at UCSF. And if you look off to the side there, you can see we have new buildings down in Mission Bay. That's the hospital, the Children's Hospital. But we are very, very proud to be right across the street from the world famous Chase Center where the Warrior Champions are. So we're just as proud to be by the hospital, but also proud to be by the Warriors.
Yay, no, Warriors.
I know, I was gonna say, maybe I shouldn't have said that because I know you all are probably Lakers fans. Anyhow, so our group focuses simply on increasing successful quit attempts and reducing that smoking prevalence. And one of the main strategies has been to help providers do a better job at working with their patients and helping them quit, as well as advocating for equal access to cessation services, which is what LA County is doing right now. So we're really happy to be working with them. And you can see we have a new partnership with Los Angeles County. I'll talk a little bit about that later. The National Center of Excellence, and this is kudos to SAMHSA and thank you to SAMHSA for finally recognizing the importance of really tobacco-free grounds, integrating cessation into treatment practices, both behavioral health and primary care. And our goals, as you can see here, educating as many behavioral health and primary care clinicians as possible. One of the other things that we do is we work with states, and we help each of these states that you see here, we're up at about 24, to create action plans to reduce the prevalence of smoking in the behavioral health field. And you can see we haven't yet gone to California, but we do have other work, and I'll be talking about that. We're also a national partner of the CDC Tips campaign. I want to put this up here. You're going to get these slides so you can scan and get all these great resources. And this is Rebecca. She is the one of the tips from former smokers that is talking about her depression and how quitting smoking actually helped her with her depression. All right. So now I'm going to sort of bring us all up, I think, to an equal playing level here and understanding of tobacco use in the behavioral health community. Yes, we all know, especially living in LA County, I'm sure, and in California, smoking rates are down. You don't see as many people out there in the community, but just to kind of highlight the deadly toll that has come from, earlier years, since '64, cigarettes have killed about 20 million Americans, and 2.5 of those never smoked. And then you can see this awful statistic here about 100,000 infants. This currently accounts every year to over 500,000 deaths, right? And of those, you're looking at about 40,000, again, who never smoked. You can see the cancer rates. 16 million adults live with smoking-related illness. And this is, for example, as you see here, COPD, chronic obstructive pulmonary disorder. A lot of people, when they smoke, think, I'm just going to keel over one day and die, have a heart attack or something. But unfortunately, what happens is there's a much longer, drawn out list of debilitating diseases that people have to live with. And that is actually one of the points of the CDC Tips from Former Smokers ads. And then you can see ultimately that cost. An economic impact when you think about the healthcare expenditures, the lost productivity of $300 billion a year, right? And then, yes, currently we're doing pretty well, but we still have about 31 million smokers out there. I think that may be going up slightly since the pandemic, but 75% daily smokers, 14 average, and that also has been going down. So that's kind of good news, but it's still a lot. I think you probably all know this, but just having this visual, smoking really does affect pretty much every organ in the body, including the brain. And with secondhand smoke, this was from the Surgeon General's 50th anniversary report, we have found out that there are even more areas that smoking affects. And on this one for secondhand smoke, the more recent discoveries is childhood depression and bruxism in children. So there's no safe level of smoke. So moving on, this is the data as it relates to behavioral health and smoking. And remember, when I'm talking about these numbers, a lot of the times it's actual souls, right? Individuals who've passed on, but at the same time, it's individuals who are addicted to nicotine. So just keep in mind, it's not just statistics. So we've got about 25% of the population here in the US that has a behavioral health condition. You can see those who have more, two or more. Or one or more. And then with that particular population, so if you're looking at 25% of the population, that group smokes 40% of all the cigarettes sold in the US, 2 to 3 times higher than the general population. So somebody's making quite a bit of money off of this group. I mean, 40%, 25% of the population smokes 40% of the cigarettes. That should tell you something right there. And then in addiction treatment settings, so addiction treatment settings where people go to feel better, get better, recover, you're looking at 53 to 91% of individuals smoke within these settings. That's sort of an oxymoron. And then unfortunately, they're more likely to die from tobacco-related illness in treatment for the drug that they're in for rather than that drug. Does that make sense? So more deaths than alcohol or drug use bringing clients to treatment. And those death rates among tobacco users are 1.5 times the death of other addiction-related causes. So all put together, it is a minimum of 10 years life lost, individuals dying early. There are studies that are up to 25 years earlier than the general population. You can see about 250,000 deaths. Adding to that, of course, right? Cancer, smoking, you're probably thinking, of course, but with mental illness as well, it's another heavy hitter. In general, lung cancer is the biggest killer for both men and women. In addition, cigarette smoking is that #1 cause of cancer, lung cancer. So if you piece it all together and you think about these individuals in the behavioral health community that smoke, 50%, more than 50% of individuals with terminal cancer have at least one psychiatric disorder. And then those individuals with mental illness may develop cancer at a 2.6 times higher rate. And this is mostly because of that late stage diagnosis. They're not getting the treatment that they need, whether that be the providers that aren't asking, or they are not going in, or they don't have access to that treatment. So ultimately, you've got individuals with mental illness that have a higher rate of fatality due to cancer. Another reason why their loss of life is so early. And then we've got, what do you want to say? The triple whammy here. COVID comes along, and yes, of course, here we are again with those with behavioral health conditions also being more likely to contract COVID. Cigarette smoking definitely compromises the immune system, if you didn't all know that, and it's associated with an increased risk in general for pulmonary infection. So COVID comes along, it's going to increase the severity of illness among COVID-19 patients. They're more likely to go to the ICU, be put on the respirators, and unfortunately die. And you can see here the recommendation from CDC, basically, if you smoke, quit. If you don't start again. Don't ever pick it up. So this is just a different way of looking at things. These are literally preventable causes of death. So what we could have done to prevent people from dying in these different arenas. So to the right there, you've got weight, obesity, you have drug-induced suicide, motor vehicle, alcohol, homicide, HIV. You add all of those up and you still do not equal the amount of deaths that occur that are attributed, that could have been prevented every year, over 500,000 deaths every year attributed to tobacco. I think this is always a shocker. And then just for perspective, in 2020, you can see about 375,000 individuals died from COVID. So you keep every year for tobacco, unfortunately, even since my whole career here, it's pretty much been steady. Hopefully it'll start going down, but we're looking at over 500,000 and every year, and not just in the past 3 years. And then that second line there, that little sort of flowery line there, is represents the individuals that die every year with a behavioral health condition who smoke. So that's about half of the half. So yes, I think that just sort of tells you all where we're looking at. And we do have progress. We're happy to say, in working with the NASHPID, the National Association of State Mental Health Program Directors, we're now looking at psychiatric hospitals going free. We're up at 96%, nearly 100%, all doing this on their own accord. Now, the psych hospitals were left out of the Joint Commission measures that said all hospitals have to be tobacco free. And there's a whole backstory to that I will refrain from at this point, but just suffice to say, there was a little bit of tobacco industry marketing and advocacy work going on behind the scenes, but they were left out. So this is actually a really big deal that they are now going tobacco free. So kudos to them. And you can see the prevalence is going down, and this is in the behavioral health community. So those who smoke with a behavioral health condition is now going from, back in 2008, 41% down to 25. But as you can see, I've highlighted there, you've got still that 2 times double the rate of those who don't have a behavioral health condition who smoke. So it is a disparity, and all of these populations are affected by tobacco use, and smoking is among the marginalized, and it is a social justice issue. There's no reason why all these individuals should be at the highest rate of smoking. It's what you heard from Norma talking about at the beginning in that video. It's just, there's something we've got to do here. We're looking at a social justice issue. So I gave you like a bunch of data, right? The individuals, and you kind of understand where we are as a nation. But at the same time, I really want to emphasize that there are reasons behind this. We don't want to just point the finger and say, hey, they just smoke a lot, right? We're going to have to help them quit. But no, there are so many reasons behind this, as you can all imagine. First of all, nicotine is highly addictive. It's more addictive than heroin. And we're looking at one of the most difficult things to quit. And this population, unfortunately, has had industry-funded research that has pushed cigarettes towards the community. Funding paper research that says, nicotine or smoking will ease your client's symptoms and make them feel better. And you can, in essence, control them a little more and help them through treatment. And going in to communities that are serving the homeless population or the LGBTQ population, and bringing cartons of cigarettes to these organizations, along with the papers that, say this is going to help your clients. And so therein starts the process. Oh, we need more cigarettes. Can you get us more cigarettes? This is great. It is working. And it became this whole cultural norm. And that up in the upper left there, Project SCUM, is from PM Philip Morris, and that stands for Subculture Urban Marketing. And that was literally the title of their service going into these, underground kind of communities that they felt they could work with. And really what was happening is it was just masking symptoms. And unfortunately, somebody ends up really trying to smoke more and more and more and more to keep it steady, and unfortunately becoming more addicted, getting more of the tobacco and the toxins in their system. And then off to the bottom left there, you can also see how the marketing is always said, if you smoke, it's going to ease you, it's going to relax you, and even going so bold with merit there in the schizophrenic ad for getting your symptoms down. One of the bigger pieces I'd say for this community, everybody's been target marketed, right, by the industry, but in addition, they're faced with lots of trauma, and exposure to all sorts of trauma will, especially prior to the age of 12, will increase that person's chance of taking up smoking at an earlier age. And there's ACEs, adverse child experiences. The more they have experience, it can be anything from, living in an abusive relationship or witnessing abuse or divorce or death. But the more ACEs that an individual has, the more likely they will to take up smoking early, to smoke more, to smoke longer, and to suffer from the consequences. And you heard, we were talking earlier, but the delays at accessing care and quality care, and which is so great to know that LA County is really working at trying to get out there in the field and offer these options for people. It's very important. But excuse me, social determinants of health is what ends up happening, right? You've got where you live, work, play, get your care or lack thereof, has a huge part. And that's where you see those disparate communities and the marginalized. Adding to that, you've got stigma from providers, stigma from the community, and you might have a clinician that's like, you know, hey, I have tried so many times and you still can't quit. What is wrong with you? And really what we're trying to do is turn it to what has happened to you, right? What has brought you to this situation right now? And having an empathetic tone and believing in that individual that they can quit. And that is where you're getting more into a trauma-informed care approach, which is essential. I'm going to dig in just a little bit to each of these things that I was just saying. But here's just a different way of looking at the adverse child experiences. So you can see there with the 5 or more, 21% of those with a 4+, oops, sorry, I meant to put 5, ACEs report the early initiation of smoking compared to only 5.5 without. So that's just proof is in the pudding. And then the myths. So I want to go quickly and make sure that you all pay attention here so you don't believe any of this stuff that's been put out there. So the first one is tobacco is a necessary self-medication, right? Oh, it's going to help individuals, or the person who smokes feels like it's helping them. So what is happening, and as I mentioned earlier, it literally is, tobacco is masking, or nicotine is masking their symptoms, but it's very short-lived. And so an individual, say, who has schizophrenia or even is just in chronic depression may feel like it's making them feel better. But it's literally masking for such a short period of time. And that's one reason why you may have somebody who smokes heavier, wanting to keep that feeling, keep it going, end up becoming more and more addicted. In addition, people may think, oh, it's making me feel better. I'm so stressed out. I want to have that cigarette because I know it eases my symptoms. It makes me feel more relaxed. Where in fact, what's happening is that part is short-lived. And what ends up sort of happening to the individual is they're just responding to withdrawal. And it becomes sort of this vicious cycle where they think it's the cigarette, but instead they have withdrawal symptoms and they have that cigarette and it makes them feel better. So it's a vicious cycle. Industry has supported this whole myth that it actually does help, where in fact it doesn't. They're not interested in quitting. That's just been refuted. It's the same percent that wish to quit as the general population. You're looking at about 70%. And they can't quit, right? Oh, I've tried everything, nothing works. Let's just treat them for something else. And this is also wrong. You're looking at quit rates that are the same depending on where you are, maybe slightly lower than the general population. And that could just be because they're not given appropriate treatment, need a little bit of longer duration NRT kind of thing. Now, this is another big one. Quitting worsens mental health and addiction recovery. Right? It's going to mess them up. They need to be stabilized. We don't want to do this. Let's just let them have their cigarettes because they're already being treated. They're already going through withdrawal from alcohol. We don't want to do this to them. It's actually the opposite. It's the opposite, folks. So quitting actually improves mental health and increases sobriety, especially for alcoholics, by 25%. That's long-term sobriety as well by 25%. And it is literally the opposite. So we just had a webinar, I think it was last week, where the whole presentation was how quitting actually can improve mental health. And so trying to flip it and think, wow, is cessation actually a way to treat mental health? Because it will increase positive moods to the equivalent of an antidepressant. And knowing if you quit at the same time, quit cigarettes at the same time that your drug you're in treatment for, 25% increase in long-term sobriety. I mean, that's another one that's been buried. And then finally, it's a low priority problem. Smoking is the biggest killer for those with mental illness and substance abuse, as I showed you earlier. So there's just absolutely no way it could be a low priority problem. This is just another way of looking at what I was saying. This was from the Cochrane review, a meta-analysis of 26 papers. And the group, all the information led to cessation decreases depression, anxiety and stress and increases that positive mood and quality of life. I highlighted those two messages there. The effect sizes of smoking cessation is equal to or greater than the antidepressant drugs for mood or anxiety disorder. It's equal to an antidepressant if somebody quits smoking in terms of the positive effects. And then with smokers, pre-existing alcohol, you can see that there, less likelihood of reoccurrence, and then that 25% increase. So just put that in your brain and remember that one. So SAMHSA has figured it out, and their recommendation is for all of their facilities to adopt tobacco-free facility grounds and integrate cessation into behavioral health care treatment. And as such, you are going to learn a lot about all of this later in the day. So I'm only going to just quickly touch upon it, but I just want you to know there's so much out there to help you do a great job to help your patients live longer, healthier lives. There's counseling that many of you probably already know, but just haven't applied to tobacco dependence treatment. It's the same thing as, cognitive behavioral therapy, motivational interviewing. NRT is the same thing as medicated assisted treatment, which many of you probably already know. And then there are brief interventions. The 5 A's is the same thing as at screening, brief intervention, and referral to treatment, which is much more in the behavioral health community. And in the smoking cessation community, we have created an even briefer intervention, and that's called Ask, Advise, Refer to services in the community. For example, all these great clinics that are in the county, and in addition to quit lines. And those quit lines are going to double a person's chances of quitting. And you can see they're putting those great policies together is going to really enable the above. If you're going to make smoking more difficult, then you got to make quitting easier, right? So here is Kick It, California. Many of you probably already know it. I just want to make sure it will double a smoker's chance of quitting. And in addition, you can double a smoker's chance of quitting. So if you put that together, a clinician's advice, and you refer to the quit line, you're really giving that person a good chance. It's free. UCSD researchers, trained coaches, many of them are master psychologists, all sorts of languages. And you can see there in 2021, 27,000 users. You've got text, you've got mobile, you've got online, and for your own benefit, there's even a email referral that you can click and just send your client off to the quit line. So my whole point there is that there's sort of no reason. Now you can at least ask your client, do you smoke? Advise them it's the best thing you can do to live a longer, healthier life if that's the motivation. And then you can refer them to a quit line. And that could take as little as 30 seconds to save a life. And yes, the quit line does treat those with behavioral health conditions. In fact, they did a study and found out half of the individuals that were already calling over the years self-report a behavioral health condition. All right, so we're moving into California a little bit more here, and California is quite ahead of the game, so you should be proud. The state prevalence is 8.9%, and that is compared to the national, which is 12.5, which is still very good, and ranks second in the nation. So pretty good, and that's up against first, which is Utah. And Utah's done great work, but you also have to know, I think it's 60% of their population is Mormon. And for being a Mormon, you can't smoke. So they got that going for them. And at first glance, everything looks great, but I'm sure you're looking at this slide already. You're ahead of me, 2 to 3 times higher than the general population. Again, for those with a behavioral health condition. So unfortunately, Stellar California ranks 41st in the US for screening in behavioral health community in the services, 32nd in providing cessation counseling, 40th in utilization of NRT, and 46th in the smoke-free campuses. So again, I'm very glad that you're doing what you're doing in LA County. You can be the poster child for the rest of the state. And here you can see a slice and dice of the facilities. So California facilities, mental health facilities, in all of these measures here, screening, tobacco cessation, nicotine, smoke-free campus, all of that are behind the nation. And I can tell you there are some southern states and some tobacco growing states that do better than California in this realm. These are the substance abuse facility treatment facilities compared to the nation, again, behind. Some of them are doing a better job at screening and providing cessation. So here comes the California Behavioral Health and Wellness Initiative. And believe it or not, this initiative was designed to help integrate cessation into services, behavioral health services, and help facilities go tobacco-free. But as you can see, the word tobacco is nowhere on this name. That was intent, right? Because we do realize that tobacco really should be a part of a wellness approach, a part of recovery. And we don't want to just have it be this prohibition, right? A rule when we're trying to change things. So that was intentional. And here's the goal. And this piece here, encourage development of wellness activities, policies to support a tobacco-free environment. Okay, so that's the piece there. There was a cohort activity where grants were given to agencies to encourage them to take steps to go tobacco-free and to strengthen their wellness policies for nutrition, gambling, and tobacco. And this, you can see the eligibility started at minimum 20 bed, later went to 15 bed. And that was because, it's difficult to find people who really want to do this, even if they're being paid to do it. But 18 months working with us. And these are the partners from the state. And I bring these up because keep in mind, we're trying to do the wellness approach. So we had Office of Problem Gambling, we had nutrition education, obesity prevention working together with us, evaluation team at UCSF, us as the intervention and the coaches, and the state for the funders. But these divisions, so NEOP and CalGETS, are in the counties that you are in. So they operate in LA County as well. And there's free services. I do encourage you to work with them. They're amazing. So the core aspects to this, and this can apply to you in your setting, is really working on the systems that exist, the promotions that exist, what is known. And here we are working with SAMHSA's 8 dimensions of wellness. All of these put together are, what makes somebody strong and healthy and, feeling good. When one of these things is off, the rest will be affected. So for example, if somebody smokes, it's going to affect all of these. If somebody quits, it's going to affect all of these. So these are very important. This is also the message that we're trying to get across. Of course, quitting smoking benefits people, but it benefits all people. So even those with mental health and substance use disorders. And smoking can mess with mental health and complicate treatment, and quitting can improve that. And off to the left, that's one of our campaigns we put out during COVID, but it is providing that same message. And those of you who will be here, you're going to hear from Katie, who's the spokesperson. She's going to speak a little bit later on. We also promoted the quit line, and this is sort of as the last, it can be your first resort, it can be your last resort. But the point is, there's really no excuse to do nothing now because this does exist. And if you ask every patient, do they smoke at every encounter, and you refer them every single time, you're going to get something. It's going to start working. And again, we talked about this earlier. So just the importance of medications and integration into workflow. And then this last piece is really just understanding that the systems approach is really going to strengthen whatever policy you put into place, getting the whole care team integrating into workflow, having that clinician there when it comes to prescriptions on site if needed, implementing those screening tools. And really, if you've got it, leveraging your EHR system and creating like the click to quit or an e-referral to a quit line. And that's going to help you with enforcing your campus policies. So working together with this group, with these cohorts in the field, we were able to find individuals, leadership and staff that were interested in breaking through these barriers. How can we find those critical linkages between wellness and tobacco control that's going to help create sustainability? And we know what we know, but they also knew what they knew. And so it was really trying to come together, and I call it here the lunchroom, but at the same time, it's almost like a think tank and working together and evolving and trying to come up with the right answers and being able to share them then with each other as well as the public. So a quarterly process, meeting and coming up with what are the achievements that you're proud of, as well as the challenges. And you can see here, everybody was kind of at a different continuum, starting off by taking their smoke shack and turning it into a Zen garden. A lot of gardening was helping to replace those smoke breaks, to people who were just, proud that they were staying afloat because of COVID. But all sorts of different stages, people already going tobacco free, getting their CEO to approve their draft policy, really starting to change their smoke breaks to wellness breaks, and starting to help individuals quit, and some of them even having staff quit. One of the big things that came away from this group was that, changing your smoke breaks, if you're starting to reduce them in order to finally go tobacco free, you have to have alternatives. And at first they're like, well, let's make them fresh air breaks and doing this and that. But then they started to realize that being outside actually was a trigger for smoking for many of them, because they were so used to smoking outside. So they called them wellness breaks and made sure to have them outside as well as inside. And you can see these are some examples from the facilities we worked with. They used some of the money to buy the ping pong table where everybody used to smoke. And again, gardening was really big. And then to the left, there was a hydroponics that everybody learned actually a skill, got to create those veggies, learn how to eat better. And all of these services were also in concert with the nutrition office. So we got all that for free. And here are some challenges that folks would come up with. And these are the facilities themselves. I think this is Grandview in LA. So ideas for, how can we do more fun things during quarantine? Again, they had some challenging times during COVID. But also, coming up with the book clubs, or how can we actually change that mindset that tobacco use is just like alcohol and other drugs, right? Or how can we work with this one person who is just ruining it for everybody who doesn't want to quit, whether it's a client or a staff member. So all these things came out and we all worked together to solve them. So here's one example. This is Progress House, and yes, went 100% tobacco free, put all of the gambling at intake, created the intake plans and treatment plans for smoking and gambling and nutrition. They had nutrition classes. You can see the stocked refrigerator of all the new fresh goods. They were able to change their menus, working with their own residents to do that. And keep in mind, these are all residential drug treatment facilities. They replaced all of those smoke breaks with, much of it was physical activity, doing outdoor therapy with their Zen walk. They created like this, I forgot, it's like a mirage, or not a mirage, a maze of sorts, and horseshoes, disc golf, baseball, gardening and outdoor activities really changed the mindset of their clients. And they, again, moved away from smoke breaks to wellness breaks. And you can see Cindy there, and she's the executive director, and how she was really overwhelmed at the beginning, but then was just so proud at the end, realizing this is betterment for all of their clients. They're helping them even more. So she's completely sold and really happy, and they're now doing it to all of their facilities. So not just talk, not just fluff. I want to make sure you knew there's a pretty hardcore evaluation, and spoiler alert, they did all go tobacco free and create all these nutrition policies and such. One of them was all ready, but the county actually said that they had to have one area to smoke, but they were able to do 100% vape free. So believe it or not, so hopefully they'll be able to change that. But here are the procedures for the evaluation: cross-sectional, staff data was email, client data, and then paper during COVID. You can see clients that were enrolled and staff that were employed. But the measures for clients: smoking status, client staff smoking together, receipt of cessation services, wellness behaviors, receipt of wellness services, and with staff smoking policies, beliefs and attitudes, and addressing and provision of wellness services. These are the measures that they went on. Here's the timeline. And this is just the first cohort. We've done 4, and they're in the process of collecting data for the rest. Some of them started earlier to go tobacco free right out the gate. And you can see here, which was kind of good, because they were, leading the cause, and everybody's saying, wow, they already did it. But then at the same time, they were learning from that individual's mistakes, right? Oops, we went a little too early and we forgot to do this. And so others could improve in the process. And many of them went tobacco free around 10 to 12 months, and then were able to work with us in the following months. So here is client data. The policy, putting a tobacco policy in place, led to a reduction in smoking going from 54 to 26%, and an increase in NRT and pharmacotherapy from 11.9 to 25%. That's a pretty big deal. And then concurrent client staff smoking decreased from 28% to 16.7%. So this has actually not really been captured before, to show that once you put a policy in place, this can affect smoking. So that was a plus. And then with staff, it was associated with more implementation, like the sustainability of those tobacco-free grounds and buy-in, as well as more training and services to clients. And then with the wellness findings, there was an association with those who got that counseling for wellness behaviors were more likely to have lower sugary beverages consumption, more likely to have higher physical activity. And those who were smokers or had that higher physical activity were more likely to want to quit. So there is a direct correlation to that. So keep up those good wellness activities that can lead to good change. So here we are with some lessons learned that came out of this lovely think tank, trying to find that one person who might be a naysayer or who at least has a respect of clients can really help get that buy-in early. Messaging and that timeline for going tobacco-free needs to start early, well ahead of the actual implementation. Don't do this any more than 6 months. Give yourself at least 6 months to go tobacco-free. We recommend probably even more, but don't go longer than 12. And then cessation, early. There's no reason why you can't start now, no matter what, but months in advance of a policy change. And procedures, you have to make sure that you've got your enforcement in there. So what do you do with a client who relapses? You want to consider it a relapse, or do you want to consider it a violation? And then the same thing with staff, but just being consistent and knowing that, you can be, you have to treat everybody a little differently. You don't want to have just like a black and white policy. Just make sure you pay attention to that. And then the systems change is really going to help if you've got that team working together to sustain that policy. And in general, changing that paradigm from viewing tobacco as this sort of secondary issue to really being a legitimate drug that needs, tobacco use disorder. Knowing that everybody's kind of in a different place. So making sure wherever you are in that process that you're addressing the needs. Familiar language, you don't have to start, you have to at least try and make those easy connections with the group and what you already know. So NRT, MAT, etc. And the skill set that a lot of you already have is going to be very helpful to helping somebody quit tobacco. And then we found that staff in the behavioral health community are very interested in NRT, demonstrating how to use it, how to purchase it. Maybe this is because you're more used to this, but very, very interested in it. So give everybody credit for that. And the lens of overall wellness. So make sure that you're not just restricting and prohibiting, but really going after the wellness idea and having tobacco underneath that umbrella. Okay, so we're almost to the finish line here. So after this initiative went into place, this bill happened to pass, and we knew it was coming, and we were able to work with DHCS and really get this up and running. I'm really pleased to say, whether you're happy about it or not, that all licensed SUD facilities have to assess and treat for tobacco use. And this has just been starting to be enforced since July. So they're actually going out and visiting sites. And you can see the specifics here. You have to provide information regarding the effects of continued use of tobacco and its success and recovery, right? You just learned all about that today. And then you have to recommend treatment for tobacco use and have to have it in their treatment plan. And you can refer. So you can refer to the tobacco quit line. That counts. And we will be working with California SUD programs to help make this happen. So compliance, you have to complete and maintain this client health questionnaire. You can see the details there. You can, though, use a client health questionnaire that's been updated by the state. There's a template. I'll show it to you in just a second. But if you do not do any of this, there will be a citation. And they're serious about this. So, gosh, there were some changes I made here that aren't showing up. Anyway, if you look at number 47 here, that's the new updated template. So you can access this and you can get it through the slide presentation if you don't already have it. But that shows you what works. And so, yeah, so that's the change. That's what everybody has to do in the substance use facility. I hope you're already doing it anyway, and you're doing it in mental health facilities as well. These are some resources that I want to leave with you so that you know you're all set. And then you're going to hear from the other speakers that are going to help you even more. But you can get all of these from our website. We have a toolkit that will help take your facility tobacco-free, but also offers a lot of information on cessation services. It's done in a way that makes it very doable. It's not rocket science, people. We've got some 10 steps there that'll help you. There's resources in their templates, and to the right is an example of one of the pieces that's drug interactions with tobacco smoke, which I neglected to mention that yes, so nicotine is not what is killing the individual. It's not the dangerous thing. It's the tobacco smoke and all of the toxins in there that cause cancer. So it's the nicotine that hooks people and the tobacco and the toxins in that smoke that harms people. And then in addition, tobacco smoke can actually interact with medications that individuals are taking. It messes with the metabolism. So they actually need more medication to be effective if they're a smoker. So when they quit, they need less medication to be effective. So one of the side bonuses of that is less side effects, right? But just keep in mind that there are drug interactions with tobacco smoke, and there's a list there. We have curricula that already exist, you can have access to with free CEU and CME. In addition, we have a new comprehensive online training. We're partnering with the RX for Change crew that will have 5 free units. This probably will be set up by November. You can see here all the different units and the disciplines that we offer, and I'm sure some of you are on the line right now. Just want to make sure you realize that. You could go there today and start getting more units. And I do encourage you to take advantage of the existing resources. They put a lot of effort into these and understanding that they work. The messages are on task. You can see there's Rebecca noting that quitting smoking actually helped her depression, and the same thing with Katie, who you're going to hear from later. There's state activities, there's trainings coming. I think the next one is in spring, February. Free CME and CEUs. You can see just from that time that we worked in California, 5,742 folks were able to gain access to that. Follow us on Facebook, Twitter, sign up for the newsletter if you want to find out about these things. And this is one of the things we're so proud of. We're working with LA County and coming soon, hopefully, to have certified tobacco treatment specialist trainings. And this is for those of you who are super interested in just diving even deeper, being able to do it all yourself, right? And helping that individual quit smoking. And this will be designed to go with the National Certificate of Tobacco Treatment Practices, and that is in line with NADAC. Scholarship opportunities as well. So your takeaways, you saw this, I'm bringing it up again, but remember, quitting smoking benefits all. Your smoking actually exacerbates mental health symptoms and complicates treatment. Quitting smoking improves mental health and substance use disorder recovery outcomes. You can see there it supports behavioral health treatment, it can improve mental health, and it can make relapse less likely. And of course, it has immediate physical benefits. And what you can do, take advantage of those national campaigns. Please promote those facts and bust those myths. Please, please, please. Try and integrate cessation into your services. Try and adopt policies, smoke-free policies. There's no reason why you should be helping a client live longer, healthier life and allowing smoking, right? We got to keep that. You're a healthcare group. And refer your clients to cessation services, whether it's in the community or at the quit line. And please don't do it alone. And that last message down there, really remain empathetic and committed to helping all of those tobacco users quit. They're trying, believe in them. And finally, don't do it alone. Remember, we're here for you. Please contact us. And I will leave it there.
Thank you, Catherine. So much great information, really good comments in the chat box. Some folks saying that they've already started to use the toolkit. But we do have a couple of questions, and we got a couple of minutes if you're okay with taking a couple. One of our first questions was what impacts of smoking and using tobacco, I guess it's supposed to be, what are the impacts of smoking and using tobacco on mental health, aspects of behavioral health or low social and economic groups of population? I think you kind of spoke to this, but if you want to do a quickie.
Sure.
Refresh.
So the impacts of smoking on mental health, because
and low socioeconomic
right.
groups. Mm-hmm.
Yeah. Well, I mean, obviously the fact that individuals in that population smoke more, so that is definitely going to impact their health and obviously loss of life. But the bit about exacerbating the treatment, I would say, is maybe where they're going at, and just imagining that when somebody does take up smoking and, most likely from trauma or whatever it might be, it could be PTSD. Remember, adults with PTSD, they are, I think it's 45% of adults with PTSD smoke. So, it's the same kind of thing. But as they take that up, they're thinking that it's helping them feel better. And what it is doing is not only messing with the meds, right? As I just mentioned, the metabolism gets affected by the smoke, but it's also making them feel like maybe they're masking symptoms, but they're not. It's so short-lived that it has these individuals wanting to smoke more and more and more and more and more. And it eventually even marginalizes them. There is currently a stigma to people who smoke now in our community. So trying to recover and rehabilitate and get back into the community as a smoker is already, that's already making it even more difficult, let alone what it does to, their mind and their body. So hopefully that kind of answers your question.
Yes, thank you for that. And I don't know, I'll ask one more, and I think I have one maybe for clinician assistance. Someone asked, where could I get the updated health questionnaire form?
Oh, well, on this slide, there'll be the slide deck that you'll get. There'll be a link on that actual template, and you can see it there. In the meantime, if I can find it for you, I'll give it to Norma. And so when she sends out materials or follow-up email, you'll have that as well. But it most likely will be on DHCS website. But we'll make sure that you get it and you don't have to go searching too far.
Okay, thanks. And then the last one here, a question regarding using SBIRT with youth. And one person responded that they don't use it with anyone under 18. But I'm wondering, is there a modification that's developed for use with youth, or is that general SBIRT okay to use with youth?
Yes, yeah, definitely. You can use it. Screening, brief intervention, referral to treatment. Why would you not want to, right? It's, I know you might think, what are we going to do for youth? But I don't know if you noticed, but even with the quit line, they do serve youth. So they are helping youth quit smoking. They are helping youth quit vaping. And there should be no reason why you wouldn't want to help those individuals. I think even, the idea of brief intervention is pretty much if you don't have time to do more. And everybody deserves that attention. And if it's 30 seconds or it's 30 minutes, you should always try and do something. So it works. Yeah, it's just understanding we care. We want to do something for you. We understand there's an issue here. You can go here and this person will help you.
Okay. All righty. We have one more. I don't know, again, it's for you or clinician, but how do you assist a client with PTSD when they're decompensating due to cravings?
Well, NRT is going to help. And any kind of medicines for, the 7 FDA approved medications to help somebody quit. And when you're working with clients, especially with PTSD, and say you're a therapist and you see them regularly, you're really going to have an advantage to helping them quit. So just keep that in mind, that it can be integrated into your treatment plans and bringing it back up every time you see them. And that's one thing that the VA really does recommend, is that integrated treatment. So yes, with the cravings, highly recommend something like varenicline, depending on where they are, or combined with the patch, but that will really help them. And just understanding that they are going through withdrawal, right? And just like with any drug, it can be significant. So the idea is, just like with medicated assisted treatment, is to replace what it is that they're missing in their body, but that won't harm them.
Right. And we're going to have a full discussion, presentation at 10:10 from Frank Vitale regarding pharmacotherapy and tobacco dependence treatment. So that might be able to get more information at that time. But we are a minute over.
I have a quick question. And again, Catherine, was a fantastic talk, very inspirational. A lot of emphasis on getting people to stop smoking, not much emphasis on getting people not to start in the first place, especially kids. Do you want to spend about a minute on what we could do to prevent people from starting in the first place?
Yeah. Well, policies, right? And our state is doing a great job at that. And I think that, With the trauma piece, we have to be cognizant of that and understand that there is a risk factor for picking up smoking. So when you're dealing with youth that are faced with these things, keep that in mind and ask them if they're smoking, or ask them, think early and realize it can happen. There could be 12 years old and smoking. Well, that, the different drugs that they all pick up. So as a clinician, bear in mind, trauma has a big effect, and understanding that they will be more at risk of smoking. So you got to be aware that that's coming down the pike. And then I think in addition, these policies and showing as a healthcare group or wherever these teams are that, tobacco is not accepted because we know it's bad, or e-cigarettes are not accepted because you don't need to be addicted to anything at your age. So then there's a great campaign coming out at the state. I think it's called undo.org. Lots of resources to help kids understand. If you want to get children involved early, there's Tobacco Free Kids campaign that has so many great resources for that. And in addition, even earlier in elementary school, the AAFP has a wonderful campaign. It's called Tar Wars. But the earlier you educate, the earlier they're going to realize this prevention. Add that with the policies in the community, add that with you as a clinician understanding that they could be at risk. And we're going to do great work on prevention.